My name is Catherine George. I'm UI3 at the University of Louisville, and today I'm presenting a case of extreme metabolic alkalosis. This case is significant because alkalosis is a rare and life-threatening cause of encephalopathy in the elderly, and a pH greater than 7.65 carries a mortality rate of up to 80%. So this case is an 89-year-old female who presented from a nursing home with a 1-week history of increasing confusion and decreased oral intake. She has a history of HFpEF, AFib on Coumadin, diabetes, hypertension, and colon cancer status post-colectomy. On physical exam, she was tachycardic, tachypnic, and had dry oral mucosa and poor skin turgor. She was not oriented to self, place, or time. Her admission ABG showed a pH of 7.735 with a CO2 of 18 and an O2 of 135. BMP was significant for hypokalemia of 2.7, BUN of 30, creatinine of 1.6, and an elevated glucose at 303. She had a lactic acidosis of 4.7 and leukocytosis of 15.8. She had a UA consistent with a UTI and blood culture was positive for MRSA. She was admitted for acute encephalopathy, severe metabolic alkalosis, and sepsis suspected due to UTI. She was started on broad-spectrum antibiotics and aggressive fluid resuscitation. Her repeat ABG after initial treatment showed mild improvement to a pH of 7.57 with a CO2 of 36 and an O2 of 193. Despite treatment of her sepsis with improvement in her lactic, renal function, and electrolyte abnormalities, she remained severely alkalotic, and due to her age and comorbidities, her family decided to pursue comfort care measures only. This case demonstrates the effects of severe alkalemia on all organ systems. Cardiovascular effects include reduced coronary blood flow and predisposition to arrhythmias. Respiratory effects include hypoventilation with hypercapnia and hypoxemia. It has significant neurologic effects, such as reduction in cerebral blood flow, tetany, seizures, lethargy, and delirium. In this case, the most likely cause of her severe alkalosis was dehydration and malnutrition, causing hypochloremia, hypokalemia, and hypoalbuminemia. This was exacerbated by potentially inappropriate diuretic use at her nursing home. Common causes of metabolic alkalosis include hypovolemia, such as in dehydration, vomiting, or malnutrition, and diuretic use. Less common causes of alkalemia include excess bicarbonate, such as in the overuse of antacids, and genetic kidney disease, such as in Barter's or Gittleman syndrome. This case demonstrates the unfortunate outcomes of severe alkalosis. Treatment of metabolic alkalosis is paramount due to its associated morbidity and mortality, and should start with identification and treatment of underlying sepsis, electrolyte abnormalities, and dehydration. Additional interventions may include intubation and mechanical ventilation, hydrochloric acid infusion via central access, or enhancement of renal bicarb excretion, such as with acetazolamide or dialysis. Thank you.